Polycystic ovary syndrome, usually called PCOS, is one of the most common hormonal conditions affecting people with ovaries, especially those of reproductive age. Yet despite how common it is, many people either have never heard of it, or they have heard a few scary headlines and are left feeling confused, worried, and often quite alone. In this video, we are going to walk through PCOS clearly and calmly. We will explain what PCOS actually is, what is happening in the body, the main symptoms you might notice, how it is diagnosed, and the treatment options that are typically offered. We will also touch on fertility, long-term health risks, and practical things you can do to support your health if you are living with PCOS. By the end, you should feel more informed, more in control, and better prepared to speak to your GP, nurse, or specialist about your own situation. Welcome to Balanced Woman UK, where we provide evidence-based women's health information you can trust. Everything in this video is based on official NHS, Royal College of Obstetricians and Gynecologists, and NICE guidance, and I've linked all sources in the description below. PCOS stands for Polycystic Ovary Syndrome. The name itself is a bit confusing and, in some ways, misleading. Many people think it means lots of cysts on the ovaries, but PCOS is actually a hormonal and metabolic condition that affects the whole body, not just the ovaries. According to the NHS, PCOS is related to abnormal hormone levels in the body, including higher levels of male-type hormones called androgens. These hormonal changes can disrupt ovulation and affect how the ovaries work. When healthcare professionals look at the ovaries using an ultrasound scan, they may see many small, fluid-filled follicles just under the surface of the ovary. They're sometimes described as cysts, but they are not the same as the large, painful ovarian cysts that might need surgery. They are simply follicles that have not fully matured and released an egg. PCOS is very common, and many people have it without realizing. The NHS states that PCOS affects around 1 in 10 people with ovaries in the UK. Some people have obvious symptoms like irregular periods, excess facial or body hair, or weight gain. Others may have milder signs or find out only when they're investigated for something like difficulty getting pregnant. It is important to stress that PCOS is not your fault. You did not cause it by something you did or did not do. It is a medical condition with complex hormonal and genetic factors. It helps to briefly look at how the menstrual cycle usually works. In a typical cycle, the brain and the ovaries are in constant communication through hormones. The pituitary gland in the brain releases hormones called FSH, follicle-stimulating hormone, and LH, luteinizing hormone. These act on the ovaries and help a group of follicles to develop each month. Usually, one of these follicles becomes dominant, matures fully, and releases an egg. This process is called ovulation. At the same time, the ovaries produce estrogen and progesterone, which help regulate the cycle and prepare the womb lining in case a pregnancy occurs. If there is no pregnancy, hormone levels fall and the womb lining is shed, which you experience as a period. In PCOS, this finely tuned system is disrupted. Hormonal imbalances make it harder for follicles to mature and for ovulation to happen regularly. As a result, periods can become infrequent, irregular, or sometimes stop altogether. The ovaries may contain many small follicles that have not fully developed, which is what gives that characteristic polycystic appearance on an ultrasound scan. Menstrual cycle can be a big deal for many, but it's not their fault. It can be tricky. Check the description and pinned comment for a link to watch our video on how your period really works to help you understand the menstrual cycle perfectly. Now, let's get back to the video. PCOS is strongly linked to changes in hormones and how the body responds to insulin. The NHS explains that many people with PCOS have insulin resistance. Insulin is a hormone made by the pancreas that helps move sugar from the bloodstream into the cells, where it can be used for energy. When the body becomes resistant to insulin, it needs to produce more and more insulin to keep blood sugar levels in a normal range. This higher level of insulin can have several knock-on effects. Firstly, high insulin can stimulate the ovaries to produce more androgens, such as testosterone. Although everyone produces androgens to some extent, people with PCOS often have higher levels than usual. This can lead to symptoms like extra facial or body hair, acne, and thinning hair on the scalp. Secondly, insulin resistance is linked to weight gain, especially around the tummy area, and it can make weight more difficult to lose. Some people with PCOS have a higher body weight, others have a weight within the healthy range, and some are underweight. PCOS is not simply a weight problem, and blaming yourself for your weight is both unfair and unhelpful. There are also changes in other hormones, such as LH, FSH, and sex hormone binding globulin, which together contribute to irregular ovulation and the typical pattern seen on blood tests and scans. The NHS highlights several common symptoms. One of the key symptoms is irregular or absent periods. You may have fewer than 8 periods a year, cycles that are much longer than 35 days, or periods that stop altogether for months at a time. Some people also notice very heavy or unpredictable bleeding when periods do come. Another major symptom is signs of higher androgen levels. This can include extra hair growth in areas where men typically grow hair, such as the face, chest, back, or tummy. This is known as hirsutism. Some people also experience acne, particularly on the face, chest, or upper back, and thinning hair on the scalp, or a pattern of hair loss similar to male pattern baldness. Weight changes are common, especially weight gain or difficulty losing weight, which may be more noticeable around the abdomen. However, as mentioned, you do not have to be overweight to have PCOS. Fertility issues can also occur because irregular ovulation makes it harder to conceive naturally, though many people with PCOS do go on to have successful pregnancies with or without treatment. Other possible features include darker, thicker patches of skin in body folds such as the neck, armpits or groin, called acanthosis nigricans, sleep problems, low mood, anxiety, and reduced self-esteem, particularly because of the physical symptoms. It is important to say that no single symptom proves you have PCOS. Symptoms overlap with other conditions, so a proper assessment is essential. If you suspect you might have PCOS, the first step is usually to book an appointment with your GP. They will ask about your menstrual cycle, any symptoms you have noticed, your medical history, and any family history of hormone or metabolic conditions. PCOS is usually diagnosed using a combination of clinical features, blood tests, and sometimes an ultrasound scan. In adults, healthcare professionals often use what is called the Rotterdam criteria. Under these criteria, you can be diagnosed with PCOS if you have at least 2 of the following: irregular or absent ovulation, which shows up as irregular periods, clinical or blood test evidence of higher androgen levels, for example, hirsutism, acne, or raised testosterone on a blood test, and polycystic appearing ovaries on an ultrasound scan. An important point which the NHS emphasises is that other conditions that can cause similar symptoms must be ruled out first. For example, thyroid problems, raised prolactin, or other hormonal disorders can cause irregular periods and need different treatment. So your GP will usually arrange blood tests to check a range of hormones and possibly your blood sugar levels and cholesterol as well. For people under 18, diagnosis is a bit more complex because irregular periods and acne can be fairly common in teenagers anyway. In younger people, doctors may wait a few years after periods start before making a firm diagnosis and will be particularly careful not to overdiagnose PCOS. You do not need to have an ultrasound scan to be diagnosed with PCOS if your symptoms and blood tests are already clearly pointing in that direction. But scans can sometimes help clarify the picture. If your case is more complex or you are struggling to conceive, you may be referred to a gynecologist, endocrinologist, or fertility specialist. One of the most worrying aspects of PCOS for many people is the impact on fertility. Irregular ovulation can mean fewer opportunities for an egg and sperm to meet, and it can therefore take longer to become pregnant. However, having PCOS does not automatically mean you will not be able to have children. Many people with PCOS conceive naturally. Others may need a bit of help to encourage regular ovulation or to time intercourse or insemination more accurately. The NHS explains that lifestyle changes, such as aiming for a modest weight loss if you are living with a higher body weight, can sometimes be enough to improve hormone balance and restore more regular ovulation. In other cases, medication is used. A common first-line treatment in the UK is a tablet called letrozole, which helps stimulate ovulation. Clomiphene citrate is another ovulation-inducing medicine sometimes used. If tablets are not effective, you may be offered other options, such as injections to stimulate the ovaries, or assisted reproductive techniques like in vitro fertilization or IVF, depending on your circumstances. It is very important to get personalized advice because every person's fertility situation is different, and age, partner factors, and other health conditions all play a role. If you have PCOS and are thinking about getting pregnant now or in the future, having an honest discussion with your GP or a fertility specialist can help you understand your options, timing, and any extra monitoring you might need during pregnancy. PCOS is not just about periods and fertility. Because of the link with insulin resistance and metabolic health, it is associated with a higher risk of several long-term health problems, especially if it is not recognized and managed. The NHS notes that people with PCOS have an increased risk of developing type 2 diabetes or pre-diabetes, particularly if they are living with overweight or obesity, have a family history of diabetes, or come from certain ethnic backgrounds where diabetes risk is higher. There is also a greater risk of high blood pressure and unhealthy cholesterol levels, which together can raise the overall risk of cardiovascular disease later in life. Irregular or absent periods mean the womb lining may not be shed regularly. Over many years, this can increase the risk of changes in the womb lining, including endometrial hyperplasia and, rarely, endometrial cancer. This is one reason why your healthcare team will want to make sure you have some way of protecting the womb lining if you are not having regular periods. Mental health is another important part of the picture. Many people with PCOS experience anxiety, depression, or significant distress because of symptoms like excess hair, acne, weight changes, or fears about fertility. Feeling dismissed or not taken seriously by healthcare providers can add to this. The good news is that these risks are not inevitable. With the right support, monitoring, and lifestyle and medical treatments, many of these long-term risks can be reduced. Lifestyle changes are often recommended as a first-line part of managing PCOS, alongside medical treatment where needed. This is not about crash dieting or punishing exercise routines. It is about sustainable habits that support your hormones and overall health. The NHS emphasises that even a modest weight loss of around 5 to 10% of your body weight, if you are living with overweight or obesity, can help improve symptoms such as irregular periods and insulin resistance. However, the number on the scales is not the only marker of health, and focusing on your overall lifestyle may be more realistic and less stressful than chasing a particular weight. A balanced way of eating that emphasizes whole foods, vegetables, fruits, lean proteins, whole grains, and healthy fats can help stabilize blood sugar levels and insulin. Some people with PCOS find that limiting highly processed foods, sugary drinks, and large amounts of refined carbohydrates helps them feel more energetic and keeps cravings in check. There is no single PCOS diet that suits everyone, so it can be helpful to work with a registered dietitian if you are able to. Regular physical activity, whether that is brisk walking, swimming, dancing, resistance training, or any movement you enjoy, can improve insulin sensitivity, support mood, and help manage weight over time. Aim for something achievable and enjoyable rather than perfection. Sleep and stress management often get overlooked but are crucial. Poor sleep and chronic stress can worsen insulin resistance and make it harder to manage appetite and energy levels. Establishing a regular sleep routine and using stress management techniques such as mindfulness, breathing exercises, yoga, or counseling can be surprisingly powerful. If you have a history of disordered eating or find that focusing on weight is triggering, it is very important to let your healthcare provider know so they can support you in a way that is safe and sensitive. Medical treatment for PCOS is tailored to your symptoms, your priorities, and whether or not you are trying to become pregnant. There is no single PCOS pill that fixes everything, but there are several effective options to help manage different aspects of the condition. If you are not trying for a baby, combined hormonal contraception, such as the combined pill, patch, or vaginal ring, is commonly used. These methods regulate the menstrual cycle, reduce androgen levels, and provide endometrial protection by giving you regular withdrawal bleeds. They can also help with acne and reduce excess hair growth over time. For people who cannot take estrogen, a progestogen-only method may be used, but additional strategies might be needed to manage androgen-related symptoms and protect the womb lining. To address excess hair growth, medicines such as cociprindiol, a type of combined pill with anti-androgen properties, or specific anti-androgen tablets may be prescribed, although they are not suitable for everyone and need careful monitoring. Creams or other topical treatments may help with facial hair. Physical hair removal methods like waxing, threading, or laser hair removal can also be useful, and in some cases the NHS may fund laser or electrolysis for severe facial hirsutism. For acne, your GP might suggest topical treatments, antibiotics, hormonal contraception, or referral to a dermatologist for more advanced options, such as isotretinoin, depending on severity. When it comes to insulin resistance, a medication called metformin is sometimes used, particularly if you have impaired glucose tolerance or are at high risk of developing type 2 diabetes. Metformin improves how the body responds to insulin and can sometimes help regulate periods, though it does not work for everyone and can cause side effects like stomach upset. For those trying to conceive, as mentioned earlier, ovulation-inducing medications such as letrozole or clomiphene are commonly used, often alongside lifestyle changes. In some cases, other fertility treatments are considered if first-line options are not successful. Before appointments, it can help to write down your main concerns and any questions you want to ask. For example, you might want to know, how can I regulate my periods? What are my options for hair growth or acne? Should I be screened for diabetes or high cholesterol? What contraception is suitable for me? Or what are my options if I want to try for a baby in the near future? Do not be afraid to say if a particular treatment approach does not feel right for you, or if you have side effects from medication. You are allowed to ask for explanations in plain language, and you deserve to be heard and taken seriously. If you feel your concerns are being dismissed, it is reasonable to seek a second opinion within the NHS. Regular follow-up is important, especially for monitoring blood pressure, blood sugar, and cholesterol, and for reviewing how well treatments are working for you. You deserve care that is compassionate, respectful, and based on good evidence. Watch this video next.